Today, we are doing episode 1 of 3 on reviewing your results. So these days, you get those extra reports coming straight through the patient portal that can be really difficult to understand. When you get your blood drawn or have a blood test result that you're looking at, the interpretation can be challenging. So we really thought a series reviewing all of these reports that are most commonly done for patients and their families dealing with cancer that could help you to interpret them. This first episode is going to be on reviewing the CBC. That's the complete blood count, or what most people call their blood test. And we're going to review the blood counts, the blood cells that are counted, and what all that means. Keep listening for our episodes 2 and 3, where we're going to talk about your blood chemistries and your pathology reports. Cancer is just something that we all have to recognize, acknowledge, cope with, live with, struggle with, rage upon, crush, and even thrive with. This show is more than knowing and fighting or beating cancer. It's more than just relaying science, hope, and technology. Together, our purpose is to demystify cancer, take away as much fear out of the diagnosis, treatment, and process as we can, defeat its grip on our lives. This is The Cancering Show. Hey everyone, welcome back to The Cancering Show. We have a series for you that we're going to be talking about your lab reports, pathology reports, radiology reports. This is hitting close to home for me this week, and I know it'll be a few weeks before this episode comes out, but I'll tell you, I was looking at my own labs recently on a patient portal and was on the phone with my father-in-law recently, who was trying to review some labs on his patient portal while he was an inpatient at the hospital to help communicate to me and to help me to communicate to his healthcare team. So first, of course, a big shout out to Papa Pierce, Bill. We are thinking about you, and I know by the time you listen to this, you are going to be out of the hospital and doing great. But I know he's a regular listener and a cancering survivor, so we're always giving him the shout out. But I wanted to bring to your attention how to read these reports. And I know now that all of us get our reports directly released to our medical record, and to those of you who join the patient portal directly to your portal, they're really hard to interpret, and it can be scary if you don't know what you're looking at. So we're going to do a series of 2 just on lab reports because they are complex and they are very crucial to patients who are cancering, particularly patients who are undergoing any type of cancer treatment. But there are things that you're going to want to watch for after you're done with your cancer treatment and on to survivorship. First, a note about patient portals. I do want to mention that anytime these days that you go to the doctor's office, since every doctor's office is required to have an electronic medical record, they almost all versus all, and that depends, but I would say mostly all, have the option to sign up for a patient portal. And I know for all of us, we think, do I want to do this? Do I want to have another login? Do I want to have another place that I have to know or go to put in my information or have my information that I have to look up? And it seems cumbersome and maybe not necessary. And I would tell you over and over and over again, absolutely sign up for the patient portal. It is a really great way to not only have access to your information, but if for any reason you are having difficulty getting a set of records from one doctor to another, then you have direct access to those records and you can print it out and give it to that other medical team. In addition, it is a great way to communicate with your doctor or your healthcare team. So these are secure emails or messaging that goes directly to your provider's nurse. You don't have to worry about the front office, the back office, the middle office, or your message getting lost or trapped in the voicemail system. But it is an electronic message that's sent securely, and it goes directly to usually your provider or to their nurse practitioner or to their nurse. And it does take a minute to receive an answer back, but it really is a much more efficient way to communicate with that team rather than trying to call or leave a message and wait for them to call you back. And so I would definitely encourage you to sign up for that patient portal, download the app, get it on your phone, and have that information available to you, particularly if you're undergoing any sort of chronic illness, including cancer and cancering. Next, we are going to be talking today about one particular set of labs. So if you want to pause right here and go either look up a set of labs or print out a set of labs or go to a previous printout that the doctor has given you, it might help to be looking at that document while we do this. If not, feel free to listen to this and a couple of times or even, find another set of labs after you listen to it just to reinforce the information. But what you're looking for when you go look for that set of labs is what we call the CBC, or the complete blood count. And we're going to go into that in detail. So now that everybody has their complete blood count, let's dive in. The first number that you'll see there is the WBC. And that WBC is the white blood cell count. And that literally are the white blood cells, the one that look white under the microscope, meaning they do not have hemoglobin or heme or red stuff in them. And because of that, we know they're not the oxygen-carrying blood cells. They are the infection blood cells. And that is why for people who are having cancer treatment or cancering or in any type of situation where they're being evaluated in urgent circumstances like the emergency room, that white blood cell count is one of the first things that we look for because it can be very high when people are suffering from an infection of some kind, even one that we don't know where it is. We look at that white blood cell count to see if it's high. And if it's low, that can mean that patients are having a reaction to their chemotherapy that could put them at higher risk for infection. And lastly, of course, it can be dangerously low. That can give you a risk for infection even under normal circumstances, like bacteria in your body or on your skin causing significant problems because your white blood cell count is too low to protect you from even the bacteria we are normally exposed to. So when we look at that white blood cell count, we are looking for a number between 3 and 10. And you're going to notice that it's a 5 point something something, and the point numbers don't really matter that much. You're also going to notice, like somewhere in the fine print, it's going to say times 10 to the third. And that just means it's that number of 1,000. So if it's 10, it's really 10,000. If it's 3, it's really 3,000. Doesn't matter at all. Only matters when you are talking about translating what your doctor has told you into something that's helpful for you to understand. If the doctor says your white blood cell count is 30,000 and you're looking at the paper and it says 30, that's what they mean. It's just the scientific way to write out 30,000, but you're both saying the same thing. So then we're going to look at the high, the low, and the very low. So first, the high number. Anything over 10 might indicate an infection. There are several other things that can cause a white blood cell count to be elevated, including cancer. But we know that things like taking steroids or any other type of acute stress reaction can cause a white blood cell count to be elevated. So if you know you have an infection, that is one explanation. But if you don't, and it's just over 10, it doesn't always mean that there is an active infection going on. When the white blood cell count is less than 3, that usually means it's low, but there are certain circumstances where it can be normal and still be low. So that becomes up to your doctor to determine if this is normal for you. They might repeat it. They might ask about other family history or medications, or if you have a historical lab from maybe a year or two ago so that they can check that over time. But really, when we look at low and whether low means dangerously low, we have to look at a different set of numbers. Those are the ones below the whole complete blood cell count that has the white blood cells, the red blood cells, etc. If you look down below that, Then you're going to get to something that has the percentages, and it's going to name the different types of white blood cells and what each of those percentages are. So it's going to separate out the neutrophils from the monocytes, from the eosinophils, from the lymphocytes, and then the less mature cells. So when we are talking about cancer and we're talking about a risk for infection, we're looking at that neutrophil percentage. And more importantly, if you look just below that, you're going to see some numbers that say absolute neutrophils or ANC, absolute neutrophil count. And on your absolute neutrophil count, we want that number to be greater than 1,500, or again, if they're using that scientific notation, greater than 1.5. And that means that your absolute neutrophil count is high enough to fight off infection. And we use that number to make sure that it is safe to give you your chemotherapy. If it is less than that, we often will hold our chemotherapy for a week or more to wait for that number to come up on its own. We'll talk in a second about ways that you can bring it up yourself or with medication. But let's talk a little bit about below 1,500. So an absolute neutrophil count between 1,000 and 1,500 is too low for your next dose of chemotherapy, but it is not too low to require hospitalization or antibiotics or anything like that. Less than 1,000, we do consider that, or less than 1.0, we do consider that to be neutropenic, meaning low in neutrophils. And once you are neutropenic, there are some behaviors that we're going to ask you to do. First, of course, we would not want you to be around anybody who's sick, but that really applies to just about everybody that's cancering. Second, we would tell you, if you are known to be neutropenic, not to be in large crowds, particularly not to be in large crowds without a mask on. So that means if you know you're neutropenic and you have to go to a wedding or a funeral, you would need to go in a mask. And if it's possible that you could skip, for example, the movies or a concert, we would encourage you not to go, because it is in large crowds that someone who is neutropenic would be more likely to pick up an infection, particularly something more dangerous like a respiratory infection. Next, there is a level less than that. So if you get to below 500 on that neutrophil count, then we worry about a risk for a very serious infection. We consider that to be critically low. If you have a fever or chills or generally feel very poorly, you need to seek care at an emergency room. Most of these times, the patient is diagnosed with low counts because they came in, because they were feeling poorly. Obviously, we would not expect you to know what your count is while you're sitting at home, but it is something that we follow. And if we find that you are very low, those patients can qualify for treatment, meaning injections to stimulate the growth of neutrophils in the bone marrow, and would qualify for preventative dose antibiotics. Now, if you're found to have a low neutrophil count, less than 500, and have a fever, then you're actually required to be admitted to the hospital on IV antibiotics, waiting on IV blood cultures to confirm that there's no blood infection, and awaiting those counts to come up to a level that we consider it to be safe for you to go home and that we've adequately evaluated you for a more dangerous or more serious infection. So what do we do with these white blood cell counts in terms of their treatment? First, there is a way to treat before we give you your chemotherapy medicine. And that is what we call, or I should say, there is a way to treat right after we give your chemotherapy medicine. And in order to do that, we look at the risk of neutropenia with that particular chemotherapy. And if the risk of every patient is over 20% risk that you could have a severe neutropenia and require hospitalization, then you would qualify for an injection of what we call granulocyte stimulating factor, or medication that is given after chemotherapy, either in a dose designed as an on-body injector or delivered in a subcutaneous injection the following day. And your doctor would order that at the time that they order your chemotherapy medicine. And that supports the white blood cell counts from dropping for the duration of your cancer treatment. And then when you come back the next time, hopefully it's not too low. Now keep in mind, we've just stimulated all your white blood cells. So if you were to come in to the emergency room for some sort of evaluation in the middle of your chemo cycle, your white blood cells might be really high. And that's okay because we just gave you this medicine. Sometimes it can indicate infection, but sometimes it's just the medicine. Now, there are other people who qualify for that medication. Maybe the chemotherapy that they're going to get has a regular risk of less than 20% in the healthy patient. But if there are additional risk factors, including age over 65, extensive metastatic disease, recent surgery, poor nutrition, or other comorbidities, then you might qualify for that stimulating factor even if the chemotherapy itself is not considered high risk for neutropenia. So it's always a great idea to ask your doctor if you would qualify for one of those medications. And I did mention that there are injections that you can receive at the time of having critically low blood counts to support your counts just until you get out of that critical window. And then after such an episode, if you had not previously been on the long-acting injection, you would qualify for it at that time. So that is the white blood cells. Now we're going to move on to the red blood cells. Now, interestingly, I'm not going to tell you to look at the RBC. You've heard the words hemoglobin. It is abbreviated HB, or hematocrit, HCT. And those are the two numbers that tell you whether or not you are anemic. So when we think about low blood, most people by that term mean low hemoglobin or anemia. And so we don't often talk about hemoglobins that are too high. We do see hemoglobins above normal in smokers, which just means that they need to increase their oxygen carrying capacity. But for the most part, what we're talking about is low hemoglobin. And anemia can mean a few different things. It can mean you don't have enough iron. It could mean you don't have enough crucial vitamins to make new red blood cells. Or it could mean that you're actually losing blood from someplace. So how do we know as doctors which one it might be? Well, we're going to look at one of those indices that you see on that lab report called MCV. And that is the mean corpuscular volume. That's a fancy word for saying, are your red blood cells big or small? So when the red blood cells are small, or what doctors call microcytic, that means they're low in iron and they're thin and small and pale. And when they are big, that's called macrocytic, and that usually indicates that you have a low B12 and folate. So when you look and the doctor is telling you that you're anemic, but not telling you to take iron, it might actually be because you need more B12 and folate. And that's where they get that basic information. Of course, we always like to confirm that by checking those levels in your bloodstream, but that's generally what they're looking at. Now, in addition to that, it might be normal. That MCV might be between 80 and 100 in that normal range. And that can happen when you are what we call chewing up your red blood cells. And that means that they're either popping too soon when they're young and related to the chemotherapy, or it can be that you've actually acutely lost blood cells and they haven't had a time to transition into that low iron state. So keep those things in mind and do talk to your doctor. If you see anemia, of course, you can imagine patients who are cancering are consistently anemic. We use a hemoglobin of 8 to qualify for chemotherapy and usually don't transfuse unless patients are below that or are suffering from symptomatic anemia with maybe a fast heart rate, palpitations, or shortness of breath. So other than that, we do transfuse to get the hemoglobin up to the number that we want it to be. There are injectable medications to support the red blood cells in the bone marrow, but they actually carry a black box warning for patients with cancer. The medicine, erythropoietin, can actually increase the risk of cancer spread and mortality from cancer in a randomized trial. So it is not a medication that we encourage, and if at all possible, the patient can be treated with transfusion to treat the anemia and, of course, the support of those indices, whether it's B12, folate, or iron that you need to get you back to where you need to be. Last thing we're going to talk about today are the platelets, the third big category of blood cells. And those are sometimes abbreviated the PLT. And so the platelet number is measured in the hundreds. And so a number of 100, 300, even 400 can be normal. And if it's higher than that, it's usually what we call an acute phase reaction. It can be an indication of an infection or even just that there's cancer present can elevate the platelets. And you'll notice that it goes back to normal as whatever is causing it to be elevated is treated. But more commonly, when we think about cancering patients, we think about low platelets. Most chemotherapies will lower all of the blood cells, but can lower platelets in particular. And platelets are particularly difficult to treat to get them back up to normal. So the most common treatment for low platelets, platelets below 100, that therefore do not qualify for any type of chemotherapy treatment because it's too low, we usually use time. Unfortunately, there is not a medicine you can take or an exercise you can do to raise your platelets. What we do to make sure it doesn't happen again is often lower the chemotherapy dose gently to a dose that's still effective to make sure that the platelets don't get too low. Now, there are a couple of things to think about when you notice that the platelets are low and not going back up, and your doctor is thinking about these. Could there be a medication that you're taking that lowers platelets? Two common culprits are antacid medicines and medicines to prevent cold sores or shingles, like valcyclovir. So if you're taking either of those medicines and you notice those platelets are always on the low side, might be worth asking your doctor if you should come off of those. There are very rare cases where chronic anticoagulation or blood thinners can lower the platelets, also worth asking your doctor about. And we do see low platelets in people who have chronic liver disease. So if those two things are occurring together, it can sometimes complicate the cancer treatments. All of this information is very technical, but I hope that it arms you with the information that you need to, when the doctor hands you that printout of your labs, that you feel empowered to look at your numbers, say, hey, this is great news. I qualify for my chemotherapy. My bone marrow is working great, and I'm not seeing any chronic side effects in the bone marrow related to my cancer treatment. So those are the main things that I want you to take away from this and to feel empowered. And then if they are chronically low or if you notice something, don't be afraid to ask your doctor or your healthcare team for more explanation. And if you need to, listen to this episode again. I hope it helps you to better understand your doctor's language as well as your cancer treatment. And don't forget to always sign up for that patient portal. We'll meet again soon to talk about the next series of reviewing your lab results. Until then, keep cancering and take care of yourselves. Thanks again for listening. And don't forget to submit your questions at www.cancering.com. We're here for all of those questions and we'll get you the answers. This show is brought to you by the University of South Alabama Mitchell Cancer Institute. MCI is a cutting-edge cancer research and patient center built to fight cancer smarter in Mobile and Baldwin County, Alabama. Our researchers and clinicians focus daily on the struggle against cancer, serving a potential catchment population of more than 4.1 million people, with a singular focus of advancing cancer diagnosis, treatment, and prevention throughout the Gulf Coast and beyond with science, technology, and hope. Want to know more about the Mitchell Cancer Institute? Visit us at usamci.com or search for us on Facebook, Twitter, and Instagram. Mitchell Cancer Institute is a member of USA Health. To learn more about all of our hospitals, clinics, and services, visit usahealthsystem.com.